I love this quote. It indicates that nothing is casualty. Success is doing a little progress each day, and that will add up to big results. So we're going to do a gastrointestinal review. Please bear with me because there's a lot of details in the gastrointestinal system. Let's start with anatomic keys. So in the gastroesophageal junction, there is particularly some characteristics that has to do with the epithelium present. We got a junction at two different epitheliums here, one that comes from the esophagus and the other one that comes from stomach. The one that forms the epithelium of the esophagus is the squamous. It's due to squamous cells. The one that's forming the stomach epithelium, it's a different type, a columnar epithelium that will be more adapted for the aggressivity of the chloride acid present in the stomach. This is a scope view of the endoscopic, specifically in the gastrointestinal junction. In that same location, we can have disorders that can produce bleeding, like Mallory waist tearing, specifically located in that gastroesophageal junction, or what we call the lower esophageal sphincter. If we have a disorder that's called gastroesophageal reflux disease, that disorder is going to be complicated if the patient has not realized that congenitally he had other disorder called hiatal hernia. We have two types of hiatal hernia. The sliding hiatal hernia in the top and the part of esophageal hiatal hernia. When this person with manifestations of reflux, sore taste in the mouth, and exacerbation of the symptoms when laying down, also has a hiatal hernia, complications will be more frequent. One of those complications, by the way, it is the presence of acid in the gastroesophageal junction. And when that happens, metaplasia can occur, followed by dysplasia, and that's what we call a Barrett syndrome. Remember that Barrett syndrome in the change of the epithelium, the progression of the columnar stomach epithelium into the squamous epithelium inside the esophagus is one of the risk factors to develop adenocarcinoma. The other type of esophagus carcinoma is the squamous cell carcinoma. Both has very low prognosis, and patients' manifestations initially is going to be by dysphagia. Another cause of dysphagia, by the way, is a lack of relaxation of the lower esophageal sphincter, or what we call the most important and well-studied disorder called achalasia. So here we have two pictures of X-ray done with barium contrast, where we see that the sphincter has a lack of relaxation. It's contracted, does not relax, and will also cause dilatation of the proximal portion of the esophagus and dysphagia. Achalasia is going to be diagnosed with special procedures, specifically measuring the pressure in the lower sphincter, lower esophageal sphincter with a manometer. Other disorders in the esophagus has to do with the presence of a diverticulum. In this case, we call it Zenker diverticulum. And it's a problem with a diverticulum located in the hypopharynx, and because anatomical problem in the cricopharyngeal bar. When a patient has a Zenker diverticulum, this patient can accumulate saliva and also rest of the food inside of the diverticulum, and the manifestations apart from dysphagia is going to be halitosis. Other thing that we can see in an endoscopic exam is the dilatation of esophageal varices. When we see varices that are incremented in diameter, we should think that we have a problem in the liver. And the portal vein should be suffering of something that we call portal hypertension. What could occur in the liver that will produce a retrograde or backflow of the vein circulation going through the stomach, left colic vein, up to the varices located in the lower esophageal, in the gastroesophageal junction? It could be fibrosis or cirrhosis in the liver. Also, hepatocarcinoma or any other disorder that can obstruct the circulation of the portal vein system. As you know, the inferior mesenteric vein connected with the superior mesenteric vein and the splenic vein will form the portal vein that will be entering the liver. And after that, the vein circulation will go through the inferior vena cava through the superior hepatic veins. Portal hypertension pathogenesis has to do with an increase of endothelin. Endothelin is going to be responsible of elevating resistance in the sinusoids located inside the liver, and that will be that increase of resistance and vasoconstriction will be responsible of the backflow of the vein circulation up to the esophagus. On the other side, the splenic vasculature is going to be presenting an elevation of nitric oxide with the consequence of vasodilatation and hypovolemia. Compensatory mechanisms like increment of cardio output and the activation of the renin-angiotensin-aldosterone system will increment the retention of sodium and try to elevate the blood pressure. A sinusoid is in the liver is going to be disposed in different lobes. So each lobes of the liver will consist in rows of hepatocytes that will have canaliculus where the bile will circulate. Also, we're going to have between each row of the hepatocytes sinusoids. And sinusoids are going to be formed by arterial blood coming from the hepatic artery entering in the liver, and the blood flow coming from the portal vein. So sinusoids in the liver will have arterial and also venous blood. That circulation of the sinusoids inside each lobe will end in a central vein that is located in the center of each lobe. The collection of all the central veins will finalize in the suprahepatic veins that will connect to the inferior vena cava, and following up with that will reach the right atrium and right ventricle of the heart. The circulation of the bile produced by each hepatocyte will circulate up to the right or left bile duct. Both of them will connect and will form a common bile duct, and then it will connect to the cystic duct, and all the bile that is produced by the hepatocytes will be collected in the gallbladder. So every time that we eat or we ingest any medications or food, everything is going to be absorbed, digested and absorbed basically in the small intestine, and then it will be collected through the portal vein, right? It will be collected through the portal vein, and it has to pass through the sinusoids for the detoxification of anything that we ingest or process of any medications that we need to intake. So liver has different functions. The liver has a lot of functions. In the liver, hepatocytes are responsible for producing bile acids, for producing bilirubin, for producing albumin, coagulation factors, especially those depending on vitamin K, detoxification of any toxin that we ingest, and also processing some aggressive factors like, for example, alcohol. Changing subject, as you know, peristalsis of the gastrointestinal system occurs because the innervation of the vagus nerve. So we have a motility that is done by the peristalsis of each one of the fibers circularly or longitudinal fibers inside the inside of the musculary mucosas of all the gastrointestinal system, and by the action of the vagus nerve. Also by the action of two plexuses that are present inside the layers, the mesenteric and the Auerbach plexus. So in the case of the movements of the stomach, the movements should occur physiologically coming from the cardias and the fundus down to the atrium. And when these movements will occur, enough time up to when the chyme will be ready to be ready to go out of the stomach and come into the duodenum. The emptying of the stomach has a precise moment for its emptying. If the emptying occurs before, or it does not occur, or it is delayed, that is not normal, and that maybe it will be caused because we have a neuropathy, or we have an obstruction, or it's impaired because of an infection, of stomach infection. So in the case of patients with diabetes not well controlled, type 1 or 2, high levels of glucose are going to be responsible in damaging fibers of the vagus nerve, but also responsible of damaging ganglion cells present in the musculary and other layers of the gastrointestinal system. Gastroparesis, it's when the emptying of the stomach does not occur because we have a gastric electric dysrhythmia caused by the effects of hyperglycemia in the nervous located outside or inside the layers of the stomach. It is important to know that the stomach, it's prepared for the high concentration of hydroxychloric present that he has to manage in order to get a well digestion of proteins, carbohydrates, and also lipids. The mucosal inside is characterized by these folders that we see here called rugae. Those are not present in the duodenum. Duodenum is not prepared. The mucosa needs to be the contribution of the mucosal barrier, specifically by the Brunner cells, in order to increment the secretion of prostaglandins and also the secretion of bicarbonate inside the duodenum are specifically very important to not permit the damage of the mucosa. The mucosa of the duodenum is characterized by those circular folds that we see here in the initial part of the duodenum when it's surrounding the head of the pancreas. There's one congenital disorder that causes projectile vomitus that's called pylorus atresia. There's another one called esophageal atresia that can also cause vomiting, specifically in children. Those are GI pediatric disorders. Let's talk a little bit about duodenal and stomach ulcer. There are different types of disorders that can cause hypersecretion of chlorhydric acid, or HCl. So, in the presence of an ulcer located in stomach or in the duodenum, peptic ulcer disease, it's correlated with an infection called Helicobacter pylori. Helicobacter pylori in the stomach or in the duodenum can cause an acute and after that a chronic inflammation that will predispose the formation of ulcer in the mucosa of those organs. In the case of stomach ulcer, we are going to see an increment of acid. In the case, increment of acid as the responsible of the formation of the ulcer. In the case of the duodenum, usually it's not the infection per se of Helicobacter pylori, but the lowering or imbalance between the aggressive factors, in this case the acid, and a very low protective mucose and production of bicarbonate and mucose barrier in the duodenum. So that imbalance will be more responsible for the formation of ulcers in the duodenum. There's other disorder called Zollinger-Ellison hypersecretion of acid. In this case, there is a very high levels of gastrin produced by a tumor called gastrinoma. That gastrinoma will activate the production of acid on the cells of the stomach, parietal cells, and it will produce a hypersecretion of acid that will produce not only one ulcer, but several ones located in the duodenum, but also in unusual sites like the jejunum. So multiple ulcers and multiple ulcers, and also in unusual locations. Let's talk a little bit about refer pain. When we have stones in the ureter or in the kidneys, we're going to feel the pain in the rectum, and sometimes we can feel, depending on the location of the stone, in the testicle area or ground in the males. Also, appendicitis will start with a peri-umbilical pain, and then it will localize it in the lower left quadrant. When a patient has cholecystitis or any problem, cholelithiasis in the gallbladder, that pain will be referred to the right shoulder or when a patient has pancreatitis, the pain will be referred to the back or even to the left shoulder. Also, we have some type of disorders, like for example, those in the lower wall of the heart can be reflected in the epigastric zone, and even it's hurting in the epigastric. The problem is not in the abdominal cavity, but in the heart. So arrhythmias or myocardial infarction of the diaphragmatic face of the heart. With respect of the appendix, it is important to know that not always we have a pre-ileal appendix. We can have an appendix that can be retrocecal behind the cecum, subcecal towards the pelvic, or located behind the ileum. Okay, usually it's pre-ileal, but if we have the other locations, the pain, it's going to be a little bit different. Remembering that for acute appendicitis, the most important thing is timing. So steps are going to be obstruction of the appendix, followed by stasis of the bacteria. Bacteria are going to start producing gas. An elevation of the pressure inside the appendix will cause an obstruction of the vein circulation and also of the artery circulation. As you see here, the appendix, it's very well supplied by blood. We have the ileocecal artery is the one that's going to be giving the branch of the appendicular artery, and also the appendix, it's surrounded by the lower and upper groups of lymph nodes called ileocolic in the ileocolic nodes. So continuing with the progression of the appendicitis, after pressure comes up, it will get to a point where artery circulation will stop. And when that happens, the walls of the appendix are going to die, causing necrosis. They're going to be more prone to a perforation. Before perforation, we have a stage called gangrenous appendicitis. And after that, we have the perforation that will continue with peritonitis and septicemia and death of the patient. Other disorders that has to do with necrosis and perforation is ischemic mesenteric when it occurs in the small intestine, or colonic ischemic in the colon, colonic ischemia when occurs in the large intestine. Usually the zones where we are going to see the necrosis of the large intestine due to ischemic problems, it's going to be in the splenic flexure and in the sigmoid portion. Also, watershed zones are located in the hepatic flexure, but the most common one between the two is going to be the flexure, the splenic flexure. There are a lot of events that can occur in order to produce an ischemic problem in the intestine. Like, for example, thromboembolic problems can cause events of ischemic when patients have, for example, cardiovascular problems. Manifestations are going to be bleeding. Depending on the location, we are going to see hematocachia or we're going to see melena. The problem with this is that after the tissue is dead by necrosis, perforation can occur, sepsis, also alterations of electrolytes, common in elderly with colonic ischemia, dehydration, and also death of the patient. Another famous diverticulum that's also congenic and very common in patients of 2 years, male patients, 2-to-1, it's the ratio. It's Merker's diverticulum. Merker's diverticulum not only occurs in children, it can occur in patients younger than 50. Okay? There's something that will increment the risk for developing symptoms in patients with Merkel diverticulum, and that has to be in patients younger than 50, male gender, when the diverticulum is greater than 2 centimeters in length, or when we have the presence of ectopic tissue or a broad-based diverticulum or fibrous band attached to the diverticulum. Complications are going to be bleeding also, ulceration, small bladder obstruction. Merkel diverticulums like to do intussusception into the cecum because it's very close to the cecum, and also perforation. Changing subjects, let's talk a little bit about the bile duct system. So we already told you that hepatocytes are going to produce bile acids and bilirubin, right? And the bilirubin is going to be storage in the bile in secretions are going to be storage in the gallbladder, right? So we have intrahepatic ducts, and we're also going to have extrahepatic ducts. We have disorders that only affect the extrahepatic one, and we have disorders that affect the intrahepatic and also the extrahepatic. So we see that the circulation will go from left and right intrahepatic bile duct to produce a common bile duct, and that common bile duct, sometimes called choledochole, will join to the pancreatic duct, and the choledochole and the pancreatic or Windsor duct will enter the duodenum. We have a cystic duct, that's a little one that will connect to the gallbladder. Disorders that have to do with intra and extrahepatic bile duct is the primary sclerosing cholangitis, and the one that has to do with the extrahepatic one is the primary biliary cirrhosis. There are two different pathologies, but they have the same principle, obstruction of the bile duct. The difference is that the first one, PSC, it's more frequent in males, and it has to do with cholangiocarcinoma. It's a predisposition for cholangiocarcinoma. Okay? The other difference that we discussed it in the class. Other disorders that has to do with gallbladder and with bile duct is the inflammation of the gallbladder called cholecystitis. It's very painful. Usually gallbladder disorders occur in women, more frequent in women, and cholelithiasis and cholecystitis more common in women of 40 years that are taking estrogens, that are fertile, okay? And also some of stones that are form of cholesterol stones. Not all stones are form of cholesterol. We have stones that are form of calcium or other substance. But in the case of stones of cholesterol, obesity, it's also important, and hyperlipidemia. So if we have a stone here in the gallbladder, it could get stuck inside the gallbladder and it will produce problems in the emptying of the gallbladder content. The same will occur if we have an obstruction of the cystic duct. We can have an obstruction of the common bile duct, and we can also have an obstruction very close to the union of the pancreatic duct and the common bile duct entering and under the sphincter of Oddi. Okay, if the obstruction is close and it will affect the pancreatic duct, it will produce a pancreatitis, and also it will produce obstruction of the bile duct with the corresponding consequences over the liver. Okay, so when we have a pancreatitis due to a gallstone coming from the gallbladder or from the bile duct, that is called gallstone pancreatitis. And we discussed a case that indicated all symptoms with elevation of hepatic enzymes because we were affecting liver, and with elevation of amylase and lipase because it was also affecting pancreas. This is the Oddi sphincter. Talking about intestinal disorders, we have one very common nowadays that's called intestinal malabsorption. It's characterized because in the lumen, there's something that cannot be transported inside the intestinal cells. It cannot be absorbed. And because of that, it will cause usually chronic diarrhea, acetorrhea, a lot of bloating and flatulence because the bacteria present in the intestines are the ones that usually are going to be digesting, for example, lactose. Patients are not going to be absorbing nutrients, so it will produce weight loss, weakness. The causes can be celiac disease, can be inflammatory reactions, maybe some infections can cause temporary malabsorption problems. Some neoplasm and colon rectum cancer can also produce that. Secretion disorder. We talked a little bit about peptide ulcer pathophysiology. We talked about Helicobacter pylori as the one that will colonize the gastric mucosa and was the responsible agent discovered by two scientific Nobel Prize of Physiology and Medicine, indicating that was the cause of inflammation. And also the problem with pylori is that impairs the secretion of bicarbonate. So that will promote the development also of acidity, and also it will produce the ulcer. So peptid ulcer will result usually through an imbalance between gastric mucosal protective or mucosal glands, Brunel glands in the case of duodenum, and destructive factors. When we talk what is an ulcer, the ulcer can extend up to the muscularis of the mucosa. When that initial epithelium is damaged, the mucosa is damaged, and the following layers are damaged, the acid will eliminate any protective barrier, and it will produce the progressive damage into the mucosa. So, why smoking could be a factor in the maintenance, the development, and also the recurrence of a peptid ulcer disease. Mainly because it will inhibit the bicarbonate secretion of the pancreatic. It will reduce also the flow of the blood in the mucosa. It will produce an acceleration of the gastric emptying of the liquids plus the acid. So that acid will go to the duodenum earlier. And remember, the duodenum is not prepared to receive that amount of acid. And also by the inhibition of the prostaglandins. Prostaglandins are the ones responsible by protecting the mucus, but also by inhibiting the acid production. So we have somatostatin and prostaglandin as inhibitory factors acting over the parietal cells. We talked about this. I just want to mention that we can have steatorrhea present in Zollinger-Ellison syndrome because at the level of the duodenum, the pH or acidity is going to be so low that the pancreatic enzyme lipase, specifically lipase, it's not going to be functioning and it's not going to be digesting fatty acid. So those fatty acids are going to cause steatorrhea. The other thing I wanted to mention is that 20 to 25% of Zollinger-Ellison syndrome can have a gene called multiple endocrineoplasia type 1, MEN1. So people with family history of MEN1 and it's more prone to have Zollinger-Ellison syndrome. So it's also more common in men. So the mnemotechnic that I can use will be Zollinger-Ellison syndrome is common in MEN1. It's more common in men with gene MEN1 mutation. This is a chart that I did to talk a little bit about diarrheas. So the first 3 columns are indicating secretory diarrhea. Let me use my... because we're not seeing it. The pen. These are secretory diarrhea. These are going to be exudative diarrhea. Usually, I think it's that one. This is going to be osmotic diarrhea. This last one are going to be celiac disease. This is celiac disease. A characteristic of a celiac disease: malabsorption, osmotic, and steatorrhea. And this one has to do with motility disorders or function. Okay? So, secretory diarrhea has to do with electrolyte transportation in the membrane of enterocytes and are caused by bacteria that have toxins. Toxins are very important in order to produce a secretory diarrhea characterized by watery diarrhea. No blood is present in secretory diarrhea. Some medications can also produce a secretory diarrhea. Like, for example, laxants. Okay? Exudative diarrhea. Exudative diarrhea, usually we're going to see a lesion of the epithelium of the brush border caused by the action directly of the action of some bacteria that are going to be invasive. For example, Shigella, Salmonella, and Campylobacter. When they invade the epithelium, they can produce blood, pus, mucus in the lumen of the intestinal, and especially small intestine. Because the small intestine is the one responsible in absorbing the major amount of water, and this is not going to be occurring because of the presence something in the lumen, in this case, blood, pus, or other detritus, that will be causing an exudative diarrhea. It does not have to do with electrolytes, even though patients can have hydroelectrolytes disturbance. It's also present in IBS, and inflammatory bowel disease, and also in diverticulitis, because it's an infection at the level of colon. Osmotic diarrhea usually occur when we have in the lumen a substrate that will absorb a lot of water, but it cannot be ingested. It cannot be absorbed. Okay? Remember, diarrhea is when it's a disequilibrium between absorption and excretion. So we are not absorbing and we are excreting a lot of water. Also, in the case of lactose intolerance, we don't have the enzyme necessarily or partially. It works partially, or it does not work at all to do the break of lactose into galactose and glucose. So lactose will stay in the lumen and will be digested by the bacterium present in the intestine, causing gas, causing diarrhea, And usually patients that are not diagnosed are going to have chronic diarrhea. Motility disorders like scleroderma that will reduce, or any tumor, the motility of the intestine, or increase of motility like in hyperthyroidism or in IBS, okay, will be the etiology, the pathophysiology has to do with increment or slow of the peristalsis of the intestinal musculature. We also can divide diarrhea in inflammatory and non-inflammatory. Usually inflammatory diarrhea are also exudative diarrhea, and usually they are, the site that is involved is colon. So I'm talking about Salmonella, Entamoebis tolytica, amoebic colitis, responsible for producing amebiasis, Campylobacter, Yersinia, Clostridium difficile also affects colon, inflammatory bowel disease, radiation. We're going to see blood. Also, the volume of the diarrhea is not going to be big. We can present tenesmo. Tenesmo is like contractions of the rectum, right, with cramps, and maybe we can have fever or yeah. Non-inflammatory diarrhea, large volumes of water, watery diarrhea, no blood, no pus, no tenesmos. But we can have vomiting, we can have cramps, no fever, we can have nausea. Site of responsible, where is involvement, is small intestine. No leukocytes, usually Vibrio cholera, because toxins are acting. Rotavirus, norovirus, Giardia lamblia, Staphylococcus, food poisoning, or Cryptosporidium parvum, important parasite present in immunocompromised patient. This was the cause of death when HIV pandemic stroke started in USA in San Francisco. People die of Cryptosporidium parvum. Men infected with HIV/AIDS had opportunistic infection due to Cryptosporidium. Also, Clostridium perfringens will produce a non-inflammatory diarrhea. Some inflammatory diarrhea will produce osmotic diarrhea, and some will produce secretory diarrhea. Liver disorders. In between the hepatocytes, we have the sinusoids, right? Or what we call the space of Dice. There, over the endothelium of the sinusoids, we have a special cells, our protagonists, called stellate cells. Those stellate cells are the one that are going to be responsible to protect against infection or against any toxin like alcohol. So stellate cells, it's called hepatic stellate cells, also natural killers, all of them in the spice of Dice, will start the inflammation, and after that, they will be responsible at the end to form fibrosis and then cirrhosis of the liver. Every time that we have cirrhosis, the immediate consequences is portal hypertension, and after cirrhosis and portal hypertension, we are prone and with high risk of forming a hepatocellular carcinoma of liver. That's why alcohol can cause cancer, liver cancer. Cirrhosis pathophysiology has to do with portal hypertension. We already talked about this. Intrahepatically, we are not going to have vasodilators. We're going to have vasoconstriction. But extrahepatically, we're going to have vasodilatation in the splenic circulation. And that for sure will complicate the problems and will produce more portal hypertension and increment of the diameter of the esophageal varices. Let's talk a little bit about hyperbilirubinemia. We have three phases in the production of bilirubin. We have a pre-hepatic phase, an hepatic phase, and a post-hepatic phase. The pre-hepatic phase is when the group, the heme group, coming from the dying of the erythrocytes from the mononuclear phagocyte system, right? They digest, erythrocytes are dead, and we're going to have heme and globin from the hemoglobin that will transform in biliverdin. But what is interesting is that after biliverdin, we need to convert that before coming in the liver into unconjugated bilirubin, or what we call indirect bilirubin. Any disorder that will produce problems with erythrocytes, or with globin, with hemolysis, that will produce more heme groups, will increment the pre-hepatic phase and also increment the levels of unconjugated bilirubin. If we have cirrhosis or viral hepatitis that will affect the cells of the liver, hepatocytes, will affect the sinusoids, the stellate cells, we are going to have a combination of increment of conjugated bilirubin and also unconjugated bilirubin, because we're not going to be uptaking unconjugated to transform it in conjugated. And if we do that, it's going to be stuck inside, right? So the next step in the hepatic phase is going to be to transform the unconjugated bilirubin in conjugated through the action of a transferase, UDP glucuronil transferase. Anything that will affect this enzyme, partially or totally, it's going to have an elevation of unconjugated bilirubin. In this case, this happened in Gilbert syndrome and in Klinger-Nager syndrome, congenital disorders. Let's continue with the post-hepatic phase. Post-hepatic phase, after the bilirubin is conjugated, it will go through the bile ducts to the cystic duct, and it will be stored in the gallbladder. That conjugated bilirubin needs to go out of the gallbladder and comes into the intestine. At this level, anything that will obstruct the entering of the conjugated bilirubin into the intestine, for example, Dubé-Johnson syndrome or Rotor syndrome, will produce an elevation of conjugated bilirubin. Inside the intestine, by the action of the bacteria or what we call microbioma or intestinal flora, the conjugated bilirubin will again be unconjugated by bacteria enzymes, right? And that unconjugated will go back into the liver, and this is what we call the enterohepatic cycle or circulation. Some of the conjugated bilirubin, most of them, it's going to be 80% combined with feces, and it's called stercobilins. But 20% urobilinogen is going to be transformed in urobilin, and it will be excreted into the urine. That's why when we have hyperbilirubinemia, feces are going to be more brown and urine is going to be more yellow. Also, if we have an accumulation of conjugated or unconjugated bilirubin with a total level of 2.5, we're going to have icterus or jaundice. First in the skin, and then with the increment over 3 in scleras, in the eyes. Causes about what causes jaundice with predominance on the conjugated hyperbilirubinemia, I was able to indicate in bold the most important ones. I already mentioned Dubé-Johnson syndrome and Rotor syndrome, but also viral hepatitis A, B, and D, alcoholic hepatitis, cirrhosis, not meaning that because it is an hepatocellular problem with Wilson disease, we can also have elevation of both. Also, extrahepatic cholestasis, cholangiocarcinoma, acute and chronic pancreatitis, and also obstructions due to parasites like Ascaris or fasciola. Conjugated hyperbilirubinemia is also can be caused by drugs, and there's a list of drugs that can produce that. Unconjugated has to do basically with syndromes called Gilbert syndrome and Krickel-Nager affecting the transferase enzyme, hemolytic anemias, hyperthyroidism, estrogen or oral contraceptives, impaired conjugation, whatever that affects that, and the hepatic phase will elevate both type of bilirubin. We have different types of hepatitis. Hepatitis A and E are transmitted through fecal oral. Hepatitis B, C, and D through sexual activity and also through blood or some secretions, parenteral. The incubation of B, C, and D is, then B and C is long. A and E is very short. Severity depends. In A and E can be mild or asymptomatic, but in the case of pregnant women, hepatitis E can be serious. Also, mortality. In order to have hepatitis D, we need to have a previous infection with hepatitis B, because hepatitis D cannot survive without the capsule, the nucleocapsid of hepatitis B. We have a vaccine against hepatitis B that indirectly can protect us against hepatitis D. When we have both infections, it's called superinfections. Hepatitis C B and D progress to cirrhosis, and hepatitis D progresses to fulminant hepatitis. Whenever we have an infection with a virus that causes inflammation of the hepatocytes, the first antigen that will be responsible for the onset of symptoms, it's going to be the superficial antigen. We're going to form IgM antibodies against the superficial antigen. But we are not going to be using those antigens for diagnosis. The diagnosed antibody that we use, it's going to be IgM against the core antigen, IgG anti-HBC core antigen, because it's the one that will be elevated initially. IgG antibodies against the surface antigen are going to be developed lately for hepatitis B. So that one, we cannot make the diagnosis with that one, okay? When we have an acute infection with hepatitis B, we are going to have IgM positive for core antigen. When we have a chronic infected hepatitis, IgM is going to be negative, and IgG against the core antigen is going to be positive. In both infection, the superficial antigen is positive. For patients that have immunization, we are never going to be seeing any of the antigens positive. Superficial antigen should be negative. Liver function tests. We need to take a look of all the tests that can evaluate liver in a holistic way. And also take a look of the pattern of elevation, if there's any ratio that can help us make the different diagnosis of anything that could affect the liver. So when we see elevation of ALT or AST, in ALT and AST out of proportion with respect of ALP and bilirubin, that will be denoting an hepatocellular disease. Whereas an elevation of ALP and bilirubin in this proportion to ALT and AST will denote a cholestatic pattern. The actual function of the liver can be graded based on its ability to produce albumin, right? And also as clotting factors depending on vitamin K. So PT, it's also one very good test to do. Here are all the liver function tests. Gamma glutarate transferase, also elevated and obstructed. International ratio and PT. Okay, hepatocellular pattern. We have an elevated aminotransferase out of proportion with respect of alkaline. So ALT will be predominant when we have apoptosis, necrosis of tissue. Okay, so it will be predominant in acute and chronic viral hepatitis. By the way, I have it here that Wilson disease has an ALT predominant, also hemochromatosis. Okay, AST, we're going to reserve AST to alcohol and to cirrhosis, steatohepatitis or NASH, or non-hepatic, other causes, non-hepatic, for example, myopathy, other causes. Exercise also can elevate. Remember, AST, it's not only in the liver. Okay, cholestatic pattern, we're going to have hepatobiliary cases, primary biliary cirrhosis, bile duct obstruction, primary sclerosis cholangitis, medication-induced sarcoidosis, amylosis, among others. Remember that we can have an elevation of alkaline phosphate also in bone disease, pregnancies because it's in the placenta, also in malignancies like lymphoma, or in congestive heart disorders, in other type of infections. Albumin. Albumin, it's synthesized in the liver and usually 10 grams per day. So anything that will affect the production of albumin will lower the level of albumin in the serum, and that will produce problem in the balance between the intravascular and extravascular content, and usually lower albumin will cause starting with lower limb edema, but progressing with ascites. Also, patients with alcohol, they have poor protein intake. That's also a cause of lowering albumin. Other cause of lowering albumin does not have to do with GI system, it has to do with nephrotic system when we lose proteins through kidney. Prothrombin type measures the conversion of prothrombin to thrombin, and except for factor VIII, all of the other ones are synthesized in the liver, so they will require prothrombin time is measuring factor 2, 5, 7, and 10, and those are crucial for coagulation. And if the synthetic function in the liver is normal and we have a PT that's delayed, you should look for warfarin. Maybe the patient is taking something to delay PT. Okay? Or maybe it's having a disseminate intravascular coagulopathy. Okay, let's talk a little bit about cholangitis. Cholangitis is infection plus obstruction. The gallbladder cannot excrete bile, elevation of pressure, and then comes infection. Escherichia, Klebsiella, Enterococcus are the most bacteria responsible for cholangitis. That doesn't mean that the other ones in the list are not responsible. They are too, but the first three are the most common one. Acute pancreatitis, the pathophysiology has to do to the premature activation of the trypsinogen into trypsin inside the acinus of the pancreas instead of doing that activation in the lumen of the duodenum when it gets in contact with the acidity and the food in the duodenum. So that premature activation will permit a digestion of the pancreas. Very, very painful for the patient. What are the etiologies for pancreatitis? Usually alcohol and gallstones, but also hypertriglyceridemia are the most common causes for acute pancreatitis. Remember that sometimes we don't know what causes. Also, we can produce, the drugs can produce pancreatitis. There's a lot of things that can produce pancreatitis. I mentioned about toxins after a scorpion bite or poisoning. You also have autoimmune pancreatitis. You have pancreatitis after an obstruction of the Wirsum duct due to parasites, Cryptosporidium ascaris, Pronorchis, or others. Any cystic fibrosis, alpha-1 antitrypsin deficiency, smoking. Okay, so we have a lot. So for chronic pancreatitis, I would like you to remember it could be a tumor, it could be alcohol chronic intake, it could be autoimmune, or we can have some genes that will produce a chronic pancreatitis. For acute, let's leave it to gallstone and alcohol, and if we have a female, hypertriglyceridemia. Parasites. So for parasites, I made a chart indicating the where the adult lives in the host. If they produce hypersensitivity type 1 or type 4, please review that. And for each one of the parasites that are in that chart. We already talked about pyloric stenosis, and we can also have volvulus, and we can also have intussusception. It's a telescope bowel, one inside of the other. Each one of these GI pediatric disorders can cause vomiting, can cause abdominal pain, and can cause acute abdomen, which means no sounds, guarding, and tenderness rebound after palpation. That's a high tract obstruction. We can have esophageal atresia, tracheoesophageal fistula, also those that has to do with the anterior wall, abdominal wall, omphalocele and gastroschisis, pyloric stenosis, duodenal atresia, intussusception, mid-goal malrotational mid-goal volvulus, Merkel diverticulum, Hirschsprung disease that has to do with the loss of ganglion cells, especially in colon. So we have ones that will cause jejunal, or large bowel obstructions that are indicated by the asterisk. Okay. Also, we talked about constipation due to spina bifida and also anorectal malformation in perforated anus. We talked about the importance to evaluate the newborns in order to see if they don't have esophageal atresia and if they have anus. Okay, innervation problems, Hirschsprung disease, also one of the etiologies for constipation in newborns. About inborn metabolic disorders and vitamin B deficiency, we talked about Phenylketonuria, mainly a problem of an enzyme called hydroxylase. It's in phenylalanine hydroxylase, responsible of transforming phenylalanine into tyrosine. And remember, tyrosine is the product from where we're going to form melanin and L-DOPA is the precursor for all neurotransmitters, almost for all neurotransmitters. And also we talked about rickets. Rickets due to a deficiency of vitamin D and the manifestations on the epiphysis and with lower of mineralization in the large bones. Deficiency of each one of the vitamins, those that are fat soluble or those that are water soluble, are going to be manifesting by different type of disease that are listed here. And here are some examples. For example, Wernicke's encephalitis. It's a deficiency of thiamine. Thiamine is water-soluble vitamin. It's a B1, and it will produce manifestations in central nervous system with loss of reflexes, paresthesias, numbness, and a lot of other symptoms. Okay, ophthalmoplegia. Deficiency of B2, this one here, B2, riboflavin. Riboflavin, it's called araboflavinosis. It's a deficiency of vitamin B2. You're going to see these lesions in the mucosa of the mouth. Also, it can cause headaches, gingivitis, sore throat, inflammation, skin lesions, neurological disorders, blurred vision, anemia, etc. Deficiency of vitamin B3 will cause what we call pellagra, characterized for changes in the skin and also in the mucosa. And this one is deficiency of vitamin C. It's called scurvy. I remember the pirates. Pirates, they spent a lot of time in their boats with no vitamin C, and they started having petechias in the skin and also gingival and problems in the mouth as the ones that are gingival hypertrophy with very poor dental hygiene in caries. In this case, as we're showing here, because also deficiency of vitamin C. So obesity, remember that problem with obesity is not only the presence of adipocytes, but also the action of adipokines. So adipokines are going to be responsible for a prothrombotic activity and inflammatory in all tissues where they are present. We can have different types of fat distribution. If it's around the circumference of the abdominal, it will have predisposition for cardiovascular disease. And obesity, the main problem with obesity, it's not only the predisposition to cardiovascular disease, is also that it will start with insulin resistant secretion, will cause chronic low-grade inflammation, which may alter glucose and also lipid metabolism that will contribute to cardiometabolic risk in visceral obesity. Also, there are genes that are related with obesity, FTO gene. Also, when with cardiovascular events, we have myocardial infarction, but also the increase of risk of strokes. Remember that when we have obesity, we also have elevation of lipids, cholesterol, VLDL, LDL, and elevated triglyceride levels. Please review each one of these charts. Here I'm indicating through each one of the organs, for example, esophagus, each one of the disorders, symptoms, and some of the key points that are important for each one. The same way for stomach, for example, for small intestine and for large intestine. Here I also did it for other problems. When we have any of the symptoms under this, you're going to find for pancreas, for gallbladder. In the next slide for bleeding, okay, if it's an upper bleeding or if it's a lower bleeding. For neoplasm, some of the genes implicated in neoplasm of the esophagus, of the stomach, and in the case of small and large intestine, very important to review the family, the FAP, the family genes, the family polyposis, or the Lynch syndrome, familial adenomatous polyposis, or called FAP, and also remember that they have like two different genes, one that's autosomic dominant, the other one that's recessive. And we also have the Lynch syndrome that it's also hereditary, but it's not producing polyps, but it can produce cancer. Okay? The other one, hepatocarcinoma, we have some of the genes here for your review. For pancreas, we talked about MEN1. We talked about MEN1 for Solinger-Ellison. Remember, but it also has to do with pancreas carcinoma. Okay. For cholangiocarcinoma. And this is the end of the review. The best wishes for you in the exam. Bye.